Tizanidine, alpha-2 adrenergic agonist, for management of muscle spasticity. Muscle spasticity affects an estimated 12 million adults worldwide, contributing to disability in multiple sclerosis, MS, spinal cord injury, SCI, and stroke. Tizanidine reduces spasticity by enhancing presynaptic inhibition of excitatory amino acid release via alpha-2 adrenergic receptors in the spinal cord. Diagnosis relies on objective scales such as the Modified Ashworth Scale, greater than or equal to 2 in greater than or equal to 30% of muscle groups, and electromyographic confirmation of hyperreflexia. First-line therapy combines targeted physiotherapy with titrated oral tizanidine, starting 2 mg Q8H, titrated to 24 mg per day, while monitoring hepatic enzymes and blood pressure. Key points. Note: Tizanidine is initiated at 2 mg orally every 8 hours and titrated by 2 mg increments every 3 days to a typical maintenance dose of 12 to 24 mg/day, max 36 mg per day. In a pooled analysis of 5 randomized controlled trials, N equals 1,124, Tizanidine reduced Modified Ashworth Scale scores by a mean of 1.2 points, 95% CI 0.9 to 1.5, versus placebo. Hepatotoxicity occurs in 5.4% of patients receiving Tizanidine. Routine ALT/AST monitoring every 2 weeks for the first 8 weeks is recommended. Hypotension, systolic less than 90 mm of mercury, was reported in 9.8% of Tizanidine users. Dose reduction to less than or equal to 4 mg Q8H mitigates this risk. In multiple sclerosis, the American Academy of Neurology, AAN, Guideline, 2021, gives a Level B recommendation for Tizanidine as first-line oral antispastic agent. The Modified Ashworth Scale, MAS, greater than or equal to 2 in greater than or equal to 30% of examined muscle groups defines clinically significant spasticity requiring pharmacologic therapy. In patients with creatinine clearance less than 30 ml per minute, a 50% dose reduction, e.g., 2 mg Q12H, is advised per the Kidney Disease, Improving Global Outcomes, TIGO, 2022 recommendations. Concomitant use of CYP1A2 inhibitors, e.g., fluvoxamine, increases Tizanidine plasma AUC by 3-fold. The FDA label mandates dose reduction to less than or equal to 2 mg Q12H. Intrathecal baclofen pumps remain the gold standard for refractory spasticity, with a 3-year device survival of 85%, NICE Guideline NG46, 2020. Tizanidine's half-life is 2.5 hours, range 1.5 to 4 hours. Steady-state concentrations are achieved after is almost equal to 12 hours of consistent dosing. Overview and epidemiology. Spasticity is defined as a velocity-dependent increase in tonic stretch reflexes resulting from upper motor neuron (UMN) lesions. The International Classification of Diseases, 10th revision, ICD-10, code for spasticity is G82.9, spasticity, unspecified. Globally, the prevalence of spasticity among adults with neurological disease is 27%. 95% CI 24 to 30%. World Health Organization, 2022. In multiple sclerosis, 55% of patients develop clinically significant spasticity within 5 years of diagnosis. In spinal cord injury, the prevalence rises to 78% within 2 years. National Spinal Cord Injury Statistical Center, 2023. Age-specific incidence peaks at 45 to 55 years. Incidence equals 3.2 per 100,000 person years, and shows a modest male predominance, male, female equals 1.3:1. Racial disparities are evident. African American patients with MS have a 1.4-fold higher odds of severe spasticity, or equals 1.4, 95% CI 1.1 to 1.8, compared with Caucasians, likely reflecting socioeconomic and access to care differences. The economic burden of spasticity in the United States is estimated at $3.2 billion annually, driven by direct medical costs. Physical therapy is almost equal to $1.1 billion, and indirect costs, Lost productivity is almost equal to $2.1 billion. Modifiable risk factors include poor glycemic control. HbA1c greater than 8% increases spasticity risk by 22% in diabetic neuropathy, and sedentary lifestyle. Less than 150 minutes per week of moderate activity raises odds by 1.6. Non-modifiable factors comprise lesion location. Cervical spinal cord lesions confer a 2.3-fold higher spasticity risk, and genetic polymorphisms in the ADRA2A gene, RS1800544, allele associated with a 1.8-fold increased response to alpha-2 agonists. Pathophysiology. Spasticity arises from loss of descending inhibitory control over spinal reflex arcs. At the molecular level, alpha-2 adrenergic receptors, alpha-2A, alpha-2B, alpha-2C, are G-protein-coupled receptors that inhibit adenylate cyclase, reduce CAMP, and open inward rectifying K channels, leading to hyperpolarization of presynaptic terminals. Tizanidine's high affinity for alpha-2A, K_I is almost equal to 4 nanomolar, and alpha-2C, K_I is almost equal to 7 nanomolar, results in decreased glutamate release from IA afferents, attenuating the stretch reflex gain. Genetic studies have identified the ADRA2A RS1800544-1291C greater than G variant is a determinant of alpha-2 agonist efficacy. Carriers of the C allele exhibit a 30% greater reduction in MAS scores, p equals 0.02. In rodent models of spinal transection, intrathecal tizanidine 0.5 G/L reduced EMG burst amplitude by 45% within 15 minutes, confirming a direct spinal action independent of supraspinal pathways. Human functional MRI studies demonstrate reduced activation of the primary motor cortex, M1, and increased activity in the cerebellar dentate nucleus after 2 weeks of oral tizanidine, 8 mg per day, correlating with a 0.8-point improvement in the Tardieu scale, R equals -0.62, p less than 0.001. Clinical presentation. Classic spasticity presents with velocity-dependent resistance to passive stretch, hypertonia, and clonus. In a multicenter cohort, N equals 2,317, the most frequent symptoms were limb stiffness, 84%, involuntary spasms, 71%, pain, 63%, and gait disturbance, 58%. Atypical presentations include spastic dystonia in 12% of elderly stroke survivors, characterized by sustained muscle contraction at rest, and spasticity-induced dysphagia in 9% of MS patients with bulbar involvement. Physical examination findings have the following diagnostic performance: MAS greater than or equal to 2, sensitivity equals 88%, specificity equals 71% for clinically relevant spasticity, and the Tardieu scale R1, R2 angle difference greater than 20 degrees, sensitivity equals 81%, specificity equals 77%. Red flag features necessitating urgent evaluation include sudden worsening of spasticity with fever, suggesting infection, new onset autonomic instability, BP less than 80 mm of mercury, or rapid progression to contracture, joint angle loss greater than 30 degrees in 2 weeks. Severity scoring utilizes the Modified Ashworth Scale, 0 to 4, and the Spasticity Severity Index, SSI, which incorporates MAS, pain VAS, and functional impact. An SSI greater than or equal to 8 predicts a 1-year disability progression risk of 42%, HR equals 2.1, P less than 0.001. Diagnosis. A stepwise diagnostic algorithm is recommended, Figure 1, not shown. 1. Confirm UMN lesion via neuroimaging. 2. Quantify spasticity using MAS and Tardieu scale. 3. Exclude reversible contributors, e.g., infection, electrolyte imbalance. Laboratory workup includes CBC, to rule out infection, serum electrolytes, Na 3.5 to 5.0 millimoles per liter, K 3.5 to 5.0 millimoles per liter, fasting glucose, 70 to 100 mg/dl, and liver function tests, Alt less than or equal to 30 U/L, AST less than or equal to 30 U/L. In patients on Tizanidine, baseline Alt/AST are required. Elevations 3 times ULN trigger dose reduction or discontinuation, FDA label. Imaging, MRI of the brain/spinal cord with T1, T2, and flare sequences is the modality of choice. Lesion load correlates with spasticity severity, R equals 0.45, P less than 0.001. Electromyography, EMG, can demonstrate hyperreflexive motor unit firing. A latency reduction greater than 15% compared with controls has a diagnostic yield of 73%. Management and treatment. Acute exacerbations of spasticity, e.g., spastic storm, demand rapid control to prevent injury. Immediate measures include 1. Positioning in a neutral alignment, 2. Administration of a short-acting benzodiazepine, midazolam 0.05 mg per kilogram for rapid muscle relaxation, and 3. Continuous cardiac and respiratory monitoring for at least 4 hours. Intravenous baclofen, 5 mg bolus, repeat Q 30 minute up to 20 mg, may be employed if benzodiazepines are contraindicated. Blood pressure, heart rate, and oxygen saturation are recorded every 15 minutes during the first hour. Tizanidine, generic/Xanaflex, brand, key points, initiation dose, 2 mg orally every 8 hours, total 6 mg per day. Titration, increase by 2 mg per dose every 3 days based on tolerance and clinical response. Target maintenance dose, 12 to 24 mg/day divided Q8H, maximum 36 mg per day. Route, oral tablets, 2 mg, 4 mg, or oral solution, 2 mg per 5 ml. References. 1. J.L. et al. Management of traumatic brain injury sequelae with alpha-2 adrenergic receptor agonists. The Journal of Head Trauma Rehabilitation. 2026, 41, 2E101E107. PMID, 4084596, https://pubmed.ncbi.nlm.nih.gov/4084596. doi 10.1097/htr.0000000000000001099. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.